Well, good evening, friends. Today, we are going to discuss managing our complications, the social aspects. We keep discussing the technical aspects, but as long as we are operating, we are bound to have complications. Today, the topic would be, to begin with, to introduce the topic. The complications are very different. There are two kinds of Indias which I have always propagated: the corporate India and the district level India. So this particular type of discussion today, you see, when you work in a 400-bedded corporate hospital and one has a biliary leak, nobody comes to know when it is tented a floor below or above in GI suite. When a patient bleeds at middle of night, big team is available and 10 units of blood is available. The patient is re-explored or embolized without much fuss. The security guards in the hospital, they are guarding the barrier between the clinician, patient, and the family. The finance department continues to collect the money, and the pharmacy continues to supply meropenem at the rate of 2,999, the highest possible market rate, and people pay also. Compared to a young surgeon in a district practice or a smaller setup where he is working like a P2P, that would mean from proprietor to peon. He has all the responsibilities, and every small thing he has to arrange. This lecture is not a substitute to the technical or academic lacunas, which have to be dealt on merit. But few things we are going to discuss will help the surgeons to have more peace of mind, more satisfied patients, and better following. Such lectures cannot cover the act of is the audio okay for everybody?
Yes, sir, loud and clear.
Okay. This kind of lectures cannot cover the act of omission and commission. They cannot hide the technical incompetency. But if you are competent, concerned, and hardworking, few tricks or the skills can make your patient more satisfied. And you see, anything which happens to our patient which was not expected to happen is thought to be a complication. And as Professor Moshe says, minor complication is one which happens to somebody else. You know, the Cleven's classification, if followed, nearly 90% patients will have some kind of complication. And varying from grade 1, where a patient required an antiemetic injection, to grade 5, where the patient died. Now, if we socially look at a complication as perceived by the patient, family, and well-wisher, is complication is the difference between what one expected and what actually happened. So it's how we take our patient and their families along with us through the journey called preoperative, operative, and the recovery from there on. I have been very fortunate to work with some of the Americans in India and some of the Americans in America. You see, they tell everything sugar-coated. They carry the family along with and convey everything. In next few minutes, I would like to share some of the common interactions which happen between the patients and the surgeon in pre-operative period. So a normal OPD concept, communication would be, do I need this surgery urgently, doctor? Can I wait for this gallstone to be operated 6 months later? So very smartly you say, well, you can wait, but you do stand some chances if the stone slips down. There is a risk of complication, but it is up to you. Some people do not have a problem even for 10 years, and somebody might have the stone slip down maybe tomorrow morning. I don't know. I wish, then they would say, I wish you don't have that complication. The usual question we face in OPD is, will this case be done laparoscopically only? A smart answer would be, yes. First they say yes. And then with a pause, they say, good 98% of my patients are done laparoscopically. But my dear child, I will act in your interest and treat you like my own son or my brethren, depending upon what your age is, what phase of life you are. And let me assure you, I will do a safe cholecystectomy, whether I do a laparoscopic or an open cholecystectomy. When can I go home, doctor? I have a party day after. What I learned to share such people is surgery and marriage is once a lifetime affair. It happens once, it is good. The repeat is not good. So with some jovial words, you can say, most of my patients go home on day one, but depends how your perioperative period is. Some of them take 3 days. Once in a while, if your intestine is struck there, and we might have to make a small cut on your belly, and you may take 5-7 days. So plan ahead. Don't get operated when you have an event important in your life few days ahead. So similarly, on the cost, most of us are poor on cost assessment. So it is good to refer them to the administration in a bigger hospital, in a smaller hospital. If you commit, then honor that cost. Suppose a complication develops. When I'm talking for young surgeons, district surgeons, if a patient develops some kind of sepsis, some complication, it is worthwhile to keep your hospital bill frozen, what you committed. Because if you are putting in more labor, the patient is also spending more on drugs. So show some compassion. It will happen once in a while only. So Dr. Eggleston, when he would make his preoperative rounds, he will tell every patient, well, when you get up, don't worry if you have a tube in your nose. Sometimes we have to put a tube in your duct. So he would mentally prepare the family. Then with a pause, he would say, I don't know whether you are going to need it or not. I hope not. But still, it's my duty to tell you that some of the patients on whom I do cholecystectomy, those days open, They used to do operative cholangiogram in everybody. And once in a while, there was a T-tube. So the patient and family will not be surprised to have a tube. One very important, now, this is initial preparing the family with confidence regarding the anticipated complications, prognosis, and long-term outcome. Now, once you have finished the surgery, when you come out of surgery, there are 3 questions which the family wants to know. Number 1, the patient is alive and conscious. Number 2, would the patient have a lot of pain, which we need to manage? Number 3, is this the full and final operation? Does this patient going to require another procedure? Now, here, for all difficult bowel surgeries, for all emergencies, a consent where even there is 5% chance, it is worthwhile taking a consent for a stoma. Stoma should never be a surprise. You see, the worst nightmare for a young surgeon or a general surgeon, this I always say, mesenteric vascular ischemia is a demarcating line between a GI surgeon and a general surgeon, because most young surgeons don't think about mesenteric vascular ischemia. When it happens, it is a real catastrophe in a smaller system or a smaller setup, when a patient is open for a bowel obstruction. When you come out of surgery, always give 5, 7, 10 minutes of discussion with the family regarding what were your findings, what have you done, where is the specimen, and we are going to discuss this a bit later, that when you finish your surgery, always start that, suppose you've done an uneventful case, then you say, okay, everything went well, tell the details. And when you expect a straightforward recovery, you don't need to much elaborate. But suppose you've done an emergency surgery and you found a lot of pus in a perforated viscus, you have done an ileostomy, it is always good to start. There is a good news that the surgery went well. Then give a pause and then say, there is another news which is not that good. Don't say there's a bad news. Say, there's a news which is not that good. And that is, to save his life, we had to do a stoma. So when you're talking like this, always take a paper and pen, draw the picture. It is amazing that when you spend your 7 minutes with the family, when you look at them, how they later on are sitting outside your office, explaining the other family members that, look, this was the disease intestine, and they will be holding your piece of paper and always with a smile say, this paper is for you, you can take it with you. So for them, it is a prized possession. Regarding their father, this is an important document. So draw it nicely, label it nicely, so that the family and the common man can understand. Now, when there are major issues, if everything is going well, whether you have elaborated in much detail or not, it does not matter. But when a major complication happens, something like Clavin 3 or 4, for example, if the patient has got major sepsis, that means the hospital stay will be increased, the drug cost will be increased. Patient has gone in septic shock, is shifted to ICU, the hospital bill will increase. The patient has post-op bowel obstruction, needs re-exploration. The operative cost will increase. Patient has arrest and revival or has acute renal failure. The hospitalization cost, mortality, morbidity, everything will increase. So these are the issues where you need a formal breaking the bad news protocol. Now, in our culture, in Indian system, we do not train our postgraduates. This particular topic is chosen only because we don't train our postgraduates on this aspect, whereas it is a part of curriculum. When we look at the curriculum of MRCS or USMLE, this is part of the curriculum where the residents are taught how to, break the bad news when you have a complication. So currently, universally accepted protocol is a spikes protocol, where S stands for setup, P for perception of the patient, I for invitation, K for knowledge, E stands for emotion, and S for strategy and the summary. Now, when we talk about informing and taking the family along with a major complication, then let's start and let me share the knowledge with residents regarding spikes protocol. The spikes says set up an interview with the family, and when you are discussing with the family, you should have absolute privacy in a room, which should have comfortable sitting place, involve all the major stakeholders, which would mean patient, if possible, his attendants, and maybe one or two more clinicians who are part of caregiving to that patient. And at that particular time, you need to switch off your mobile phones and pagers, maximize the privacy, avoid any interruption. Tell your secretary or the nursing head or the junior not to disturb you while you are in this meeting. Make sure that you have all the information, the biopsy report, the imaging with you, which you want to share with the family. And whom should you break the news? Just find out who in the family are important. And I have found sometime besides the family, in a rural population, there is a headmaster, there is a retired subedar who controls the emotions and decision process in the family. So it is worth involving such a person who's going to make decisions on behalf of the family. And to start this interview, I would love that if you have some facility of drinking water and some tissue papers, because when you are going to tell something bad, some of the people, the lady or a gentleman is likely to cry. They need a tissue paper. We know it beforehand that tissue paper and water may be required. So such things should be always available. Now, the perception is you start after introduction of the patient. It is worth to start by saying, what do you think about his illness? What do you know so far regarding his problems? And what did your last doctor who sent you here, what did he tell you? So in this, we are trying to dig out how much the family knows about. Because the style, emotion, and contents of the patient statement provide you the information of input. Patient may be in a denial mode. And quite often what I find, the last doctor or the doctor who took consent was a resident. He only said there is some risk. He never told that 10% of such people die. They never told 5% will go on ventilator. They never said that 19% of this particular surgery will have some kind of leak. So some risk hai, kuch khatra hai, that does not convey the family. And you are not required to change the response at this phase. Be a good listener. In the perception phase, just listen to what they want. Then invite them. Do you want to know more about him? To what level you would like to know? Most people would say, half of the Indians population would say, I don't want to know much about it. You talk to my son, you talk to my spouse. And then you also need to ask, to what level of detail you want to know. Then the fourth aspect is K for knowledge in Spike's protocol. That you have to open-minded discuss the diagnosis, the treatment, prognosis, and the support. Aligning from patient's starting point. What would be the next stage? What are the anticipated complications and problems? Always give the information in small bits. Do not blast with a lot of data. Just tell them that now, after this surgery, once the wound heals, we will involve a chemotherapist and radiotherapist. You may require one of them. You may require both of them. You may require them simultaneously. Well, it is in your interest. Now, when you talk to the family, listen to patients' agendas. I have so often, while I talk to the ladies with breast cancer, their only worry is about their hair loss. They don't know their life in a metastatic disease is limited, but their concern is hair loss. So you assure them on hair loss, but at the same time, you would like to discuss with them that for these side effects of chemotherapy, you are bound to get these benefits at some risk of complication. Then the E of the spikes is emotions. Patient can respond with distress, denial, anger, that I have done nothing wrong. Why me? Why should I be suffering for this? Allow expression of emotion without any criticism. Just smile over. You should be looking concerned. The last point is strategy and summary. Demonstrate the patient and understanding of care. Let the family understand what is fixable and what is not fixable. Prepare them for the worst and give them hope. For example, if somebody tells me that, look, my father is re-explored, what are his chances? I would say majority of them get well. Well, there are 10% who's come to this disease process. At the same time, I hope it is not your father comes in that category. So this is Spike's protocol. We have discussed where we have highlighted the formula of Spike is S stands for setting up, P for perception of the patient, I for invitation, K for knowledge, emotions, and strategy and summary. Now, having said that, we need to evaluate ourselves. The fact that I did 10 Whipples when I was an assistant professor in PGI Chandigarh, can I give the same results in a small town? Answer is no. I should evaluate my team, what all I could do. And then that is what all you should do. Communicating the family, anticipating the problems is important. We need to build our own team to get through the social problems of complications. Because more you operate, more complications you have. All my life, I have dealt 40 surgical patients. There was always somebody who has gone on ventilator, somebody has a secondary bleed, somebody who has a bowel obstruction. When you do high volume, your complications will be proportionately high. But tackling them, like if my one of prostate spikes 104 with UTI, I would tell family beforehand, well, he had infection, and now every infection we anticipate, some of them have rebleed. So I will tell rebleed beforehand. If I've done an ileostomy closure, if on day 1 or 2 the patient is not doing well, I will tell beforehand. Even before taking up ileostomy closure, I would say some of them get obstructed again and they might require another surgery. I will try my best that your uncle does not require it. But I cannot same time promise and guarantee that such a thing will not happen with you. Now, for young surgeons who are working in solo practice, for young surgeons who just started their career, there is, I'm reaffirming, there is a role of a surgical uncle in your vicinity. Who is a surgical uncle? A person, either he knows more than you, or the public thinks he knows more than you. So always keep such a person on your right side so that when you need him, when you have complication, he should come for your help quickly, regardless of the time, day or night. Now, how can you get such people closer to you? Number one, never criticize the old man. You may be very good in lap hernia and he still may be doing open hernia. You may be doing a good laparoscopic hysterectomy. The old man still may be doing open hysterectomy. But remember, he has faced more complications. He has treated generations in that area. So keep him on your right side. How can you keep him on your right side? Just be respectful. Visit him once in a while. Offer him to cover when he is not available, sick or on holiday. Go and assist him once in a while. You should, there are many things to learn. Somebody who is old and successful, he has some kind of art and technology with him, with which he has grown. So it is good to be friendly to such a character. And when I say surgical uncle, a person who knows more than, I mean, I have surgical, I am uncle to many, and I have surgical uncles too. I mean, my GI medicine uncle is a year younger to my daughter. But well, he is helpful to me. He knows more GI than I know. So he's my GI uncle. So keep these people pampered. Remember today's lecture, the formula, the care, courtesy, and currency. These are three things not given in the book. I repeat, care, courtesy, and currency can make friendship with any other person. You need to send him some patients once in a while, say for second opinion. sir, you also have a look, or I would like you to operate this case. You come over, operate, or you operate in your place, I will come and assist you. Some kind of liaison you should have. It cannot happen that you never talk to that man, and at the middle of night, one day you call him up and, sir, I did a hysterectomy in the morning or gallbladder in the morning, and now the patient is in shock. Please come and help. Nobody is going to come and help. All those professional, moral principles are down the drain if you do not follow care, courtesy, and currency, right? So, Dr. Habib, we will come to all the questions. We have enough time in the end, right? So this was something about surgical anchor. So to summarize what we have tried to say, that no kind of sweet words can cover up your technical mishaps, your lack of knowledge, acts of omission or commission. They cannot be covered up by any method. But if those are good, and on top of it, you're a good communicator, you take the family and the patient along with, your life is going to be easy. And we also said, when you want to have breaking a bad news, follow a SPIKES protocol. Now everything in West is protocol driven. Actually, SPIKES protocol is part of UCMLE question. SPIKES protocol is part of MRCS exam. So unfortunately, we don't teach our boys all this. That is how this lecture has been selected today. Now, to conclude, we must evaluate our team, follow set surgical principles, communicate honestly, and have a fully informed consent. If during informed consent, if 1 out of 10 patients doesn't go away, then probably we are not doing a good job of selection of the patients. Also look at not only the technically, the social aspects. Can I satisfy a session judge in my hospital? I may be the best, surgeon for a given technique, but does my infrastructure, does my hospitality group match to the expectation of the rich and famous? If not, where is the compulsion to invite trouble for you? Just refer them away. Other point is move ahead of the complications. Think, evaluate, reevaluate. If your patient has spiked after anastomosis, you should be considering a leak, not the malaria. Be realistic. Not a lot of people have met this. हमने तो कोई गलत काम कभी किया ही नहीं, हमारे पेशेंट के साथ ऐसे क्यों होगा? हम तो भगत है माता रानी के, हम तो टेम्पल में जाते हैं. All those things are just trash. If you have to still have a bad news, follow a protocol. Remember, the time given in breaking the bad news, say 10 minutes, say 15 minutes, is worth saving a litigation in the court. You need to be confident, concerned, and compassionate. Not only you should be compassionate, the public should think you are their well-wisher. You should not think, public should not go away, no, he is only interested in money. He doesn't bother about the family. You need to sit down, you need to handhold, you need to learn a good body language techniques so that not only you care, the other party should also understand that you care. With due apologies, if you don't do that, it is like winking at a girl in dark. You know what you're doing, she doesn't know. So something like that. So in case of a complication, when the patient expenses are going up, subsidize your bill if you can. Even in corporate hospitals, if we reoperate, I have the pleasure of working sweet and sour player for 2 years in a bigger system. I mean, we can't do much about finances there, but then in a redo case, we will forego our fees. That's all what you can do. And you can tell the patient that I cannot control the finances, but I have not charged my fee. A patient who has got well after the complications, keep them follow up on the telephone. Once in a while, if you call up and say, Mr. Agarwal, how are you doing today? I hope you're well. That gives a lot of confidence to the patient. And if you follow this kind of dictum, and if you're compassionate and you communicate well, believe me, still in India, a lot of people will love you, adore you. You will have more name, fame, and money. That comes to an end. All questions are welcome. Please.
I think Habib raised his hand, but I think it's left, sir. Very, very practical lecture, I should say.
Well, I thought this because this is a question. This is an evaluation part in MRCS as well as in UCMA. But somehow we don't talk in our curriculum here.
True. Any comment, questions, anyone?
I think there are very less number of people.
Yeah.
If when we put it on record, maybe some questions which come, we will answer them later.
Sure, sir. Okay, sir. Bye.
Okay, thank you. Thank you.